Good evening. Welcome to the Center for Global Humanities at the University of New England. This is a very special occasion, a special event. We've never done this before, but I will be introducing the speaker, Dr. Lipkin, in a little bit. But before I do that, it is my great pleasure to introduce my colleague and the president of the University of New England, Dr. James Herbert.
Thank you, Anouar. Thank you very much. I appreciate that, the warm introduction. And welcome to everyone viewing this from wherever you're viewing it. I know we have people from within Maine, but also more broadly from around the country and indeed around the world. So thank you very much for joining us this evening. And I appreciate the doing this a little differently. This is the way we're living these days. It's certainly a little different, but we're accommodating. I'd like to give a thank you to Dora Mills, our friend, who also helped let a lot of people know about this lecture this evening. Maine has taken the lead in coping with the pandemic in many different ways. And I think I'd be remiss if I didn't mention our governor and the entire state government and the things that they've done to actually help us through this crisis. I've been especially impressed with the transparency of communications by the governor's office, as well as the director of the Maine CDC, Nirav Shah, and the DHHS Commissioner, Jean Lambrou. There's also been a great deal of bipartisan legislative action looking at scientifically driven policies and action. And I think that speaks well to Maine people to come together across political divides to deal with this crisis. Many of you know, most of you probably know about UNE, but just briefly, for those who may not, we are Maine's largest private university. We have a very deep footprint in the health professions. In fact, we're the largest supplier of health professionals in the state of Maine, and in fact, across all of northern New England. We have Maine's only medical school, only dental school, the largest nursing program, and a full range of health profession programs. We're known for our signature interprofessional education and interprofessional practice model, which is basically a fancy way of saying team-based care. And this crisis shows that that model has never been more relevant than now. We need people coming from across various disciplines working together to cope with this problem. Our strategic plan at UNE focuses explicitly on promoting health in a broad sense, including the health of individuals, communities, and indeed the entire planet. We're doing our part at UNE to cope with this pandemic. Our alumni are on the front lines of caring for patients with the virus. We have gathered together any excess PPE that we have and donated it to local clinics. Our medical students are volunteering to babysit and medical and other health profession students are volunteering to babysit the healthcare professionals who are working on the front lines, a group known as the Maine COVID Sitters. We have faculty lending their expertise in all different kinds of ways to both state and national agencies. For example, Megan May, one of our professors, has been featured in the Times, the Press Herald, AP, and others, sharing her expertise on virology and public health. Our Center for Aging and Health, Dr. Tom Muser, the director of that center, has been working with seniors across the state to help them reduce a sense of isolation and find support. We've got faculty and professional staff and students working on sewing masks for healthcare providers across the state. There's just many things that we're doing. And like our home state of Maine, the UNE community is very resilient and agile and pragmatic. And I'm convinced we're going to emerge from this stronger than ever. So in that spirit, tonight's lecture is especially timely. We'll be talking with one of the world's leading experts on this topic, and I'm sure you'll be very impressed. And by the way, I learned just before the lecture that he has connections with South Portland, as it turns out. So at that, I'll turn it back over to Anouar to introduce our speaker. And thank you all so much for joining us this evening.
Thank you, James. Thank you. I have the speaker, the speaker doesn't need any introductions. He is one of the world's top experts in the field, in many fields actually. So I'm gonna read a small biography and then I will let Dr. Lipkin make his presentation. And after that, I will come back and have a little conversation with him and ask a few questions if we receive them from the audience. So Dr. Lipkin holds a medical degree from Rush Medical College. He also has a background in the liberal arts, which is interesting, and anthropology as well, which helps explain a little bit his passion and his interest. He is a director of the Center for Research in Diagnostics and Discovery, and director of the Center of Infection and Immunity with the Mailman School of Public Health at Columbia University. Dr. Lipkin is internationally recognized for his contributions to global public health through the innovative methods he has developed for infectious disease diagnosis, surveillance, and discovery. He has been at the forefront in responding to many of the world's recent outbreaks, including the West Nile virus in New York City in 1999, SARS in China 2003, MERS in Saudi Arabia in 2012-16, Zika in the United States, 2016, and encephalitis in India, 2017, and COVID-19 now. And of course, one of the things he's also famous for recently is that he has been the chief science advisor to the movie Contagion, which has made a tremendous comeback in the last few weeks. So without further ado, please help me welcome Dr. Lipkin to the program.
Thank you, Anouar. Really, I would like to say it's a pleasure to be here, but I can't really. It's a pleasure to be in cyberspace, sharing this moment with you. So let me ask, first of all, whether or not you can see a slide on the screen of a fireplace.
Yes, I can.
So I'm best known really for my work in discovering viruses, but I'm interested in bacteria, fungi, a whole range of infectious organisms. And as many of you will probably know, the bulk of who we are is bacteria and viruses and so forth. They live on us, they live in us, they're in our DNA, and they have an enormous impact on who we are. Sometimes they're pathogenic. I have the John Snow Professorship of Epidemiology at Columbia. Some of you will know who John Snow was, some of you may not. John Snow was really the father of epidemiology. In the 1850s, he was the one who was responsible for identifying the cause of cholera in London, and he eventually linked it to a pump on Broad Street. For those who've been to London, you can actually see this pump. It's actually a replica of the original pump because the first one is located in the London School of Hygiene and Tropical Medicine, and lore has it that John Snow broke off the pump handle and eradicated the cholera outbreak. Now, it turns out that the outbreak was already on the wane at the time he did this, but it makes for a great story. Now, presently, as we look at viruses and bacteria that emerge around the world, we can think of a hotspot map. And in this hotspot map, you can see the areas that are concentrated for the emergence of new pathogens. They're indicated in red and yellow, and the green ones that are relatively quiet. And there are a number of features that contribute to the emergence of these infectious diseases, which are happening with increasing frequency. And Anouar alluded to some of them during his introduction. So here in white, I've illustrated those that are primarily human-to-human transmission in white, and the ones that are zoonotic, that originate in animals, are indicated in red. What we do now in searching for these primarily is to use sequencing technologies, and this is an example of an Illumina machine, but there have been many of them that I'll talk with you about during the course of this lecture. Now, how did I get into this in the first place? When I went to college, I wanted to be a cultural anthropologist and a filmmaker. Somewhere along the line, I decided that I was interested in chemistry. That led to medical school, and before I knew it, I'd done an internal medicine residency, and I was in the middle of doing a neurology residency when HIV emerged. And the thing that struck me was that it took so long to figure out why people were ill. 2 years really from the first appearance of this disease that was recognized in homosexual men, and then the link that was made to a blood transfusion when an infant, a 20-month-old infant, became infected after receiving several blood transfusions. So the causative agent was identified at the Pasteur Institute and subsequently at the National Cancer Institute, the National Institutes of Health. But the 2 years that it took to identify this, hundreds of thousands of people were infected who might otherwise not have been infected. So what I decided to do was to learn something about molecular biology, forget about my clinical medicine, because at that point I'd done internal medicine and neurology, and go back into a basic science laboratory. There was a paper that came out in 1985 suggesting that manic depression, now known as bipolar disorder, was due to an unknown virus. So what I decided to do is to spend the next several years trying to identify the agent responsible for this disease. We used a method then called subtractive cloning that allowed you to look for genetic material that was different in two populations, an animal or a human with disease and another that didn't have that. This took me several years. In contrast to this paper, which, as I say, took several years to produce, we now have a whole range of tools that we can use. In the early 2000s, I worked with a company called 454 that was purchased by Roche, that was the first to develop high throughput sequencing. Then more recently with Ion Torrent and Illumina and the nanopore system, which is a small system that can actually run off of a laptop. As you can see there, it's running out of a USB-C slot. But with this sort of an approach now, we can identify a staggering number of infectious agents. These are 1,500 viruses that we've discovered in a period of about 10 years. I would say 10% of them have proven to be clinically significant. The other thing that we've been doing, in addition to using sequencing for identification of genetic footprints, is to look for host response, antibodies directed against bacteria and viruses that allow us to recognize a link between an infectious agent and a disease, even if we can no longer find the infectious agent. So we use this tool for a disease known as acute flaccid myelitis that some of you may have heard about. It looks similar to polio. We found that there were children who had antibodies directed against an enterovirus known as D68. This was found only by using serological methods. This sort of an approach has been helpful for identifying links to prenatal infections with herpes viruses and with influenza viruses and autism. And I think it will also find links to cancer. So the future really of this sort of pathogen discovery is going to entail not only genetic methods that find evidence of viruses and bacteria, and unfortunately today I don't have time to talk with you about the microbiome, but in addition, using these antibody methods to make links to infection that might otherwise not be apparent. This is a list of a series of recent global outbreaks: Marburg, Ebola, Nipah, SARS. I've been involved with many of these and sorting them out, typically using genetic methods. And today we're going to focus primarily on the new coronavirus associated with COVID-19, but I'm going to illustrate some principles to you that I think you're going to find important in thinking about what's coming up next, because this is not the last new emerging virus that we will see. And I'm hoping that we will ultimately develop tools that will allow us to be more proactive. First of all, why do we have so many emerging infectious agents at present? Well, this is a slide that illustrates the factors that are important with emerging infections. We have, are we still okay in the presentation? I just want to check. Okay, good. So we have changes in the way people use land. We have new roads that are being put into areas that were formerly wetlands, that were wild, which means that you wind up having animals that are coming into contact with humans who didn't earlier come into contact with humans. We also have changes in the food industry. We have centralization of food production so that if you have large numbers of animals that are very close together, you favor the emergence of drug resistance. We have people who have had transplants, who have cancer, and we have a lot of travel. War and famine are extremely important because this leads to mass migrations. And all of these things in concert have created a perfect storm for the emergence of new infectious agents. These are other factors that are important as well. The world is very tightly linked at present. So just thinking as a New Yorker, which is what I've become over the past 20 years, you can see all these places that one can reach on a nonstop flight. And the number of tourists passing through, and here I'm just referring to international tourists, is really quite extraordinary. So all of these things have led to an increased risk of infectious diseases. And once they're inside the United States, you then have domestic travel, which carries them further. We also have an extensive problem with wild animal trade. Some of these animals are imported as pets, others are consumed. New York has a very strong wild animal trade, and this has resulted in a number of infections, both locally as well as nationally. And I could tell you the same thing about any major European city where you have people who are interested in having exotic animals. The illegal wildlife trade is larger yet. So here you can see the bushmeat that comes in undetected through our ports, 90,000 kilograms annually. France brings in more yet, and China is the largest importer of all. And I've been pushing since 2003 to try to close these wild animal markets, which are in fact an enormous risk, not only for China, but also for the rest of the world. This is an example of the kinds of things that we found looking at animals that were coming through JFK. You can see up here a non-human primate head, another non-human primate head, and we found evidence in these animals a wide range of viruses as well as bacteria. In this case, most of the meat was dry, but there's also fresh meat that is imported. So this is, again, an extraordinary risk for us all. I'm going to give you an example of how we've used molecular methods and serology to investigate unexplained diseases in parts of the world. This is an example from Uttar Pradesh, which is a northern state in India, where there has been every single year for the past decade recurring difficulties with encephalitis in children. And there are so many cases that you can see this waiting room in the front where people are camping out to be there to their children, and they're putting 2 children to a bed. A new hospital has been built with 550 beds just to house children with this problem of encephalitis, inflammation of the brain. These epidemics in these children are linked to changes in water. And you can see here that this is the Ganges River, which runs up toward Nepal and then comes back down. And annually in the fall months, you see flooding is here and here. And these are children who are known as the Musahar. They are tribal. They are the most economically disadvantaged people that I've ever encountered. And they live by eating rodents and the few rupees that they can collect for collecting rodents and pulling them out of rice fields. When we began to examine the spinal fluid of these, we found that they had many different types of infections. But the two that were most interesting are illustrated and highlighted orange at the bottom of the screen, Aurentia and Rickettsia. And this is because these are two infections that can be treated with tetracycline. So by using these kinds of approaches, genetic methods and serology, we were able to come up with a treatable disease that has completely changed the complexion of this problem. And you can see here now examples, again, of this Aurentia and Rickettsia. Both of them are actually rickettsial species. I'm going to talk very briefly about food security and climate change, because this is also extremely important. 40 years ago, we were looking at salmon that were dying globally, and we implicated a new infectious agent. I will talk today about tilapia instead because they're more important to the developing world. Major producers are China, Egypt, the Philippines, various areas in South America and Central America. In the United States alone, this is a $10 billion industry. Salmon are obviously much more expensive fish, but the point is that the loss of these animals in mariculture or in aquaculture on land is extraordinarily challenging. So using these sorts of methods, we identified infectious agent, tilapia lake virus. And you can see here by using a staining method where we're looking at specific nucleic acids that these fish have this virus in their liver and their heart and their intestines. And here in this photograph, you can see these regular structures that represent virions. This has been identified by Food and Agriculture Organization of the United Nations as a major threat to global stability and to food security. Again, emerging infectious diseases that we begin to see more of all over the world as a result of travel and trade. So we can no longer think in terms of us and them. Anything that is a challenge as a pathogen anywhere in the world is a challenge to the rest of the world. And for this reason, in 2005, the United Nations had, as part of its recommendations, the establishment of the International Health Regulations. These said that every country had to have the capacity to diagnose an infectious disease within its own borders and to share that information transparently with the rest of the world. I'm going to talk a little bit about climate change because this is an important risk factor for much of what we've been talking about. When you have dry seasons followed by heavy rainfall, this is what happened, for example, in '99 in New York. It led to the emergence of West Nile virus. You have increases in mosquito larvae. You have burgeoning of rodent populations. You have more waterborne diseases like cholera. And because people then begin consuming bushmeat because they can't grow crops because of arid conditions and so forth, you find that you have an increase in consumption of bushmeat, which leads to emerging hemorrhagic fevers. Here's an example of the mosquito associated with yellow fever. So in 2020, you can begin to see how in South America and in Central Africa and in parts of Europe, the distribution of this virus, which carries dengue fever, Zika, chikungunya, and malaria, is moving up into the southern states within the United States. And this is what happens if we do not or do control global emissions. This is what's happened to West Nile virus, an expansion of its habitat from 2010 to 2013. Again, a function of changes in climate. Lyme disease, which used to be restricted to a very small area in New England, is now expanded all over the United States. And this again is a function of climate change. Longer periods of time where these ticks are active and are biting. And climate change is accelerating the pace of climate change. So here you can see the pine beetle, which was normally eradicated in the Rocky Mountains, or not eradicated, but slowed in its progression in winter months. You can see here what's happened from 2005 to 2009. Losses of all these trees, which of course then accelerates this very process. So let's move on to coronaviruses. I can talk about MERS during the Q&A if that's of interest, but I'm going to focus primarily on coronaviruses in China. Now, this is a time-lapse photograph. This is me with Zhongnan Shen in 2003. And this is us again 17 years later in Guangzhou Airport. I became sick when I came back from China in 2003. Ironically, when I went to China this time in the middle of January, I did not become sick. However, I did become sick in New York. So where are we in terms of the number of coronavirus cases? This number is already obsolete because we obtained it this morning, and it's somewhere around 1.9 million cases, 116,000 deaths, 434,000 people who have recovered. The symptoms of COVID-19 may be none at all. You may have fever, you may have cough. I had a severe headache, unlike any headache that I had ever had before. But these are the primary features that bring people in to see their physicians. And it really doesn't look any different than a standard respiratory tract infection, which is why it's important to have good diagnostic tests. Computerized tomography of the lungs of an infected patient reveal early evidence of pneumonia. So here you can see one section through the lung of a patient. These are two different views, and you look at these areas, you can see that there's a change in the appearance of the lung, even from the earliest time where you begin to see an infiltration to here, or from here to here, or from here to here, and so forth. What happens is, as you accumulate inflammatory cells and fluid, your ability to have gas exchange is impacted. And as a result, people can die. And although we like to say that the only people who are at serious risk are those who are elderly or immunosuppressed, the fact is that we've seen cases in younger individuals as well. The timeline is unclear. The first documented case of pneumonia was in early December. However, there's more recent information coming to light suggesting that this virus was probably circulating earlier, at least in November, and that it simply wasn't picked up. Because if someone presents with pneumonia, you don't necessarily do high throughput sequencing. It's only if somebody who's astute sees that there's something different about this, that there's a cluster that's unexplained, and the usual kinds of the usual kinds of offenders are excluded, that they begin to look for other agents. This is a timeline of total cases, which, as you see, is continuing to increase. And here you can see new cases illustrated with an orange line and recovered cases indicated with a green line. There's no reason to suspect that this is going to slow down anytime soon if we relax our shelter at home policies. And this is something that I'm sure we're going to want to discuss during the Q&A. The end of this epidemic is really going to require a vaccine. And we can talk about that as well, and what the challenges are in bringing forth a vaccine. So where are we in terms of our response? There are some excellent candidate drugs that are in the pipeline. Some of them specifically interfere with the ability of a virus to replicate by interfering with its ability to make proteins or to progress through the cell and out to the cell surface or to uncoat. There are a number of targets that have been identified. There are antibodies that are useful in preventing the virus from attaching to cells. There are antibodies that suppress the immune response, because it appears as though a major factor in disease is the robust, quote unquote, cytokine storm associated with infection. Now, there is one drug that appears to be extremely promising so far, remdesivir, produced by Gilead Sciences. But there's some other drugs that are really not particularly promising. We don't yet know whether hydroxychloroquine or chloroquine are going to be useful. These are drugs that are used primarily for malaria or for lupus and other sorts of autoimmune diseases. And there currently are no drugs or therapeutics that are formally approved by the FDA. Now, our president is very excited about hydroxychloroquine and has been talking about it for a long time. And you can see this quote from the press briefing. It's been around for a long time, so if things don't go as planned, it's not going to kill anybody, and we've had very encouraging early results. And we're going to be able to make that drug available almost immediately. Well, recently, there's a paper that's come out in Medrix, which is a pre-publication archive, reporting study done in Brazil, where 2 different doses of chloroquine were used. And in the higher dose of chloroquine, in individuals who had some sort of underlying cardiac disease for which they weren't necessarily screened, there was more death, more morbidity, and association with arrhythmias. And the findings were so striking that the investigators shut down the trial before it was completed. During the Q&A, we can perhaps talk about what is meant by a double-blinded trial and what's important. But this is an example of a trial that was conducted rigorously. The physicians and the patients didn't know which arm they were getting, the higher dose, the lower dose, no dose. And there was a data safety monitoring board that continuously examined the results in either treatment arm and decided, once it hit statistical significance, that you had to shut down one aspect. And this is the case whether you're talking about plasma therapy, vaccines, or drugs. We have to be sure that whatever we're doing is going to be safe. You will have heard, I'm sure, a lot about plasma therapies. Plasma therapies are classic. The first Nobel Prize in medicine was given to von Behring for the discovery of diphtheria antitoxin, which was plasma from individuals who had recovered from diphtheria. And this actually saved people. In one study that was conducted by a close friend of mine in China of 10 patients with severe COVID, convalescent plasma led to improvements within 3 days. On the strength of this and the historical benefit in other conditions, there are plasma trials that have been established in the US as well. We're leading 4 of these right now at Columbia University, and the Food and Drug Administration is trying to provide access. Now, this is not going to get us out of the woods entirely, because as you may remember, as I showed you earlier, we don't have as many people who are recovered from this disease as we have who might need it. This means that although one individual can give 3 units of plasma once a month, we don't have enough plasma for everybody. We also don't know that plasma is going to have benefit. So until we complete the study it's premature to talk about it as being of value. Where are we on vaccines? There are at least 5 major candidates worldwide. Moderna, which is an RNA-based vaccine. There are others that are based on viruses where people have substituted the spike glycoprotein of this virus, which is the portion of the virus that attaches the host cell and allows it to gain entry. And these sorts of studies typically take 16 to 18 months to do. Now, the question is why. People frequently will ask why, whether this is a function of actually creating the vaccine or something else. And the answer is it's the latter. It's very easy to design a vaccine for this particular virus. The challenge is in testing it. Testing goes through 3 phases. In the first, we take normal volunteers who are typically healthy. We try to immunize them with this vaccine, whatever it is, and we see whether or not they develop side effects. Sometimes we find side effects that we didn't anticipate. This process takes several weeks, anywhere from 50 to 100 volunteers. The second phase, phase 2, we look for efficacy. And because we don't have a drug that will treat these individuals, we cannot accept volunteers who will take the vaccine and then deliberately expose themselves. What we can do, however, is we can go into a place where there's a lot of disease, where we anticipate that there will be infection at a very high rate, and we then test the ability of this virus vaccine to prevent disease in people who are in this climate, in this particular context. And if we find a significant difference between the two, then we assume that that virus is useful. Then we move into phase 3, where we look for longer-term side effects, and we test for efficacy in a larger group of individuals. And this process takes a long time. We then have to first talk about manufacturing and distributing the virus. You'll see when I show you the film clips from Contagion that we've truncated that process through the magic of movies. But the fact is, it takes a while to do these tests. So when people ask me, when are we going to be out of the woods completely? I have to say, with all honesty, it may wait until we have the vaccines. Now, there are strategies that we can use to mitigate risk, and I'll talk about those as well. And I'm sure that's where we're going to go as a country. That said, until we have a vaccine and everyone is protected, this is going to be a continued risk. This infectious agent is not going away. Now, I started off by talking about pathogen discovery and how this has transformed medicine and science and will continue to do so. Now I'm going to talk about some other concepts in virology that I find even more interesting. So the first is this paper that many of you may not even know about directly, but that has had an enormous impact in this country. And that was a paper that was written by Andrew Wakefield, suggesting that measles vaccine and MMR cause autism. This was not a well-controlled paper when it came out in 1998, but it is still reverberating today. And in fact, when you look at the people who have continued to espouse this, they tend to be very prominent people. So here you see our president with Wakefield, Bobby De Niro, Wakefield again, Jenny McCarthy, these Orthodox Jews, but Mormons in the same way. All of this is a challenge for us because we have a preventable disease if we could get people to take the vaccine. So when we talk about vaccination for COVID, I'm worried that there are people who are not going to be willing to take this vaccine. This is something that we haven't been able to discuss yet. It's a problem ethically, politically, freedom of speech, all sorts of ways of thinking about it. But unless we get very, very dense coverage for COVID, it's never going away. So this is something to consider. Look at the number of measles cases that are reported. Periodically, it explodes, and people and children become blind. Some children die. It's awful and completely preventable. Not just true in the United States, but globally as well. Now, this was a fascinating meeting that I attended back in March of 1999 that illustrated for me another way that we should be thinking about viruses. It was hosted by the Department of Defense in Fort Monroe, Virginia, which is a historically interesting place. And they had 3 virologists, one animal virologist, that was me, a plant virologist who pointed out that our food supply was insecure because anything that hit our monoculture, because we plant in rows enormous amounts of corn and wheat, anything that was a pathogen for any monoculture would spread like wildfire. And at that point, something that I wasn't thinking about at all, a computer virologist. And this is proven to be extraordinarily important. If you look back at the history of going viral, it really came out of advertising. And this goes back to 1989, talking about the rapid spread of information. But it's not only information, it's also misinformation. During one internet minute, there are 188 emails sent. It's close to 60 million mobile and text messages, GIFs, videos. I guess we're going to be on YouTube. Hopefully we'll have 4.5 million YouTube users, because I'd like to think that this is a good YouTube video. But you can see the point. This is an extraordinary distribution. If you look at Twitter, Donald Trump has 64 million followers, CNN 56 million, Narendra Modi 50 million. 10% of the users write 80% of the tweets, so 330 million users worldwide. An extraordinary opportunity for exchange of information or misinformation. Facebook, 2.4 billion users worldwide. Instagram, more than 1 billion and growing. And the majority of the users are young, and they get their information from Instagram. WhatsApp, not quite as popular. YouTube, as you can see, if you look at this part of the screen, the majority of people using YouTube are 18 to 24 years of age. This is the new television. It's the second largest search engine. So what does this mean practically? People turn to YouTube for content. They turn to it for news. There are the dark corners of the internet. Conduits include YouTube. And I'm not attacking YouTube per se. I'm just trying to make the point that we're all connected. So much so that when Kobe Bryant died, his wife, his widow, found out about it on Twitter before she could be contacted by the authorities. There's something wrong with that, I'm sure. And then in terms of COVID, a lot of misinformation has been spread about COVID using social media. And here are just some examples: false cures, misquotes, and xenophobia, which has had a huge impact on Chinese Americans. Xenophobia spreads like a virus. What historians hear when Trump calls coronavirus Chinese and foreign. This is a time that we all need to be pulling together. So what do we do about this? Well, my focus has been to try to use film and television and YouTube as a way to educate people. So these are some of the projects I've been involved in. Contagion, I'm going to show you a clip in a few minutes. This is another one called 3 Months, which has to do with incubation of HIV. This one is about a new influenza that wipes out the world. And this is Bond 25, where I was asked to create the secret weapon. And I had to give them 3, and I don't know which one they selected. One of the things that one can do is to use infectious disease models to think about ways in which we can insulate and isolate. During the eradication of smallpox, WHO physicians would go around, identify a case. They would then do track tracing, identify everyone who'd come into contact with that individual, and they would make sure that they were vaccinated. So this concept of ring vaccination is going to be what's going to get us out of COVID. It's also something that can be used for everything from violence to ignorance to xenophobia and so forth. And there's a very interesting project run by a physician, infectious disease expert, and former CDC person, now an epidemiologist who's trying to find ways in which he can travel around areas where there's gang violence and have an impact as well. So I'm going to show you now some clips from Contagion. This is the short version, and because it illustrates many of these points. Now, Anouar, please put your thumb up if you can hear the audio, because I have no idea whether you can or you can't.
How many people are going to die?
Well, in 1918, 1% of the population died from Spanish flu. It was novel like this. No one had ever seen it before.
1% of America.
1% of the world. With the new mutation, we are predicting an R0 of no less than 4. And without a vaccine, we can anticipate that approximately 1 in 12 people on the planet will contract the disease.
So at this point, I think we have to believe this is respiratory. Maybe fomites too.
What's that, fomites?
It refers to transmission from surfaces. The average person touches their face 2,000 or 3,000 times a day. 2,000 or 3,000 times a day? 3 to 5 times every waking minute. In between, we're touching doorknobs, water fountains, elevator buttons, and each other. Those things become fomites.
Honey? Hey, honey. Beth, Jesus. Sweetheart.
You had a seizure this morning, Beth. Have you had something like that
She have a
before?
history of seizures?
No.
Allergies, other medical problems?
I think she's
She
allergic
fall
to
recently?
penicillin.
Hit her head in the shower?
No. She came back from a trip and she
What about drugs, MDMA, ecstasy?
No, we don't do that.
Okay, let's get some help.
Beth.
Let's get a line in her.
The Centers for Disease Control and Prevention in the United States and the World Health Organization in Switzerland confirmed today that Dr. Ian Sussman of San Francisco has succeeded in growing the MEV1 virus in a laboratory setting. Officials at the CDC cautioned that the breakthrough is only the first step toward developing a vaccine, which is likely still months away from human trials. The WHO estimates the number of people infected worldwide to be over 8 million.
We'll only be able to give out 50 doses today. That's hard. Cynthia, I love it. That's... Hey, excuse me, there's a line here.
that this vaccine is a result of the courage and perseverance of a remarkable few. We shall now begin the drawing. Gun. First MEV1 vaccination are those people born on March 10th. March 10th. Remind all of you.
So about a month ago, I was talking with the screenwriter, Scott Z. Burns, and then with Steven Soderbergh about the fact that this film was now #1 in downloads on Amazon and a couple of other sites. Now apparently it's #1 in China as well. And Scott and I decided to ask the cast whether or not they wanted to help do something through public service messaging. And everybody said yes. So Damon, Winslet, Fishburne, Ely, Cotillard all filmed themselves with iPhones, sent the footage to Stephen, who edited it, did all the post-production, cleaned it up, and we posted it on our website at the Center for Infection and Immunity. We're supposed to have 2 additional vignettes, one from Bryan Cranston and another from Jude Law. And I'm hoping we're gonna be able to do those in the next several days. But this is very useful if you want to see ways in which you can protect yourself with isolation and hand washing and so forth. COVID and SARS-CoV-2 are not going to be the last of these emerging infectious viruses that we will see. I've seen at least 10. I don't even know that this one is going to be the most lethal. Therefore, for several years now, we've been proposing the establishment of a network of people who are like-minded, want to work together, sharing data, sharing technologies, sharing risk in promoting a global immune system. This network called Gideon, the Global Infectious Disease Epidemiology Network, comprises a number of core pioneer institutions around the world: Colombia, the NIH, Fiocruz in Brazil, Sun Yat-sen University, groups in Africa and Asia, Bangladesh, and so forth, all of whom have agreed in a way that they've never done before to post all of their data collectively on a single site that can be accessed not only by one another, but also by the WHO and any other Ministry of Health. The idea is that by having something which is independent of governments, that we may finally achieve the international health regulations proposed in 2005 and create a bona fide global immune system where we integrate laboratory and epidemiologic data, automate sequence analysis, allow serology to look for links to chronic disease, and to expand to include a whole range of technologies that will make the world a safer place. And I thank you so much for your attention and for this lovely invitation. And I look forward to ending with questions and trying to address whatever is of interest to you.
Thank you so much, Ian. What a tremendous presentation. And we have a lot of questions. We got a few questions from the audience. And I also have a few questions of my own. But, you know, how uncanny is it to make a film like that and to see reality basically replicate it almost like, to the smallest detail possible? Well, not exactly, but very close.
There was other stuff that wound up on the cutting room floor that was good too. But it got to 1 hour and 46 minutes. And that was about the limit to which people are willing to sit without squirming in their seats. When we made this film, the deal was that it was going to be as true to life as it could be. And it has proven, as you've said, to be prophetic. Not because we had a crystal ball, but because this was obvious that this was going to happen. Now, we made it a paramyxovirus instead of a coronavirus. But the principles are pretty much the same because people are people.
Yeah. Well, yeah. So I have a question before we move on to other questions. I really wanted to ask you in front of our audience and everybody else is how are you doing? And the fact that you got sick, and how did you take anything for it? Did you take any medication? Since there is no vaccine or no scientifically proven cure, how did you treat you? How did you take care of yourself?
Well, first of all, I am largely recovered. I wouldn't say that I have the same stamina that I had before, but I can't separate what's deconditioning from what's disease. And I anticipate that I will make a full recovery. It certainly hasn't impacted my ability to work as much as being isolated has. I had an internist who referred me to an infectious disease physician who said there are some data coming out of China suggesting that hydroxychloroquine is of value. The Chinese government wanted to send me plasma from hyperimmune Chinese patients who'd recovered. And I was very eager to take that. I love the Chinese people and I thought this would be great. I would forever be part Chinese, but I couldn't get anybody to infuse it. So I took the hydroxychloroquine. I don't think it made any difference. I will tell you this, it certainly made me lightheaded when I took the loading dose. So that's the only thing I can be certain of. But there are people who swear up and down about this, and we are sponsoring a trial now of hydroxychloroquine in healthcare workers who are at high risk for conversion, and we'll find out. But I don't think that it's not going to be the panacea that we hope it will be.
Oh, I see. But you mentioned climate change, and you talked about the things that are going viral and everything. As you know, recently Pope Francis gave a talk, and I mentioned the climate, how he really, I'm going to quote what he said. He said, "I don't know if it's nature's revenge, but it's certainly nature's response." What is happening right now? In other words, we have human beings have decimated nature to such an extent, and they have tried to control it to such an extent, and they continue to do so now by trying to overcome anything that would hinder their well-being and their comfort. So how do you really see this dynamic playing out? On one hand, humans want to overcome these illnesses and these diseases, yet at the same time, the diseases are emerging because people are not good caretakers of nature.
I agree. And I like this Pope. He's terrific. You know, compared to some of the other world leaders we have, he's a breath of fresh air. Now, I don't agree with everything he says, but on this point, I think he's on target. And he too decided to start live streaming, you know, his services and his greetings and so forth, rather than having people come and congregate and take risks. So this is clearly somebody who at least thinks about the implications of his actions.
So would you agree with that statement he made?
Well, I don't attribute any intelligence to nature. I think that, you know, I'm a sort of a Darwinian. I believe in evolution. And if we don't get our act together, we will be replaced. That's the way I look at it. But it's not going to be divine intervention. It's just going to be,
Yes.
you know, we're not going to survive.
Yeah, that's what
So
he said.
Josh Lederberg, who was a Nobel laureate, the first one to discover, so what's known as bacterial sex, you know, how the exchange of plasmids between bacteria, the exchange of information, that really was the foundation of biotechnology, said in 1999, the greatest threat to man on the planet, humankind on the planet, is the virus. And I believe this is true. The computer virus and the virus that emerges from nature, both are challenges for us.
Yes. We have a question from one of colleagues, a friend of ours, Dora Mills, who had been mentioned by James when he was addressing the audience. And she sent the question, what are the silver linings you can predict for the COVID pandemic? For instance, some way we may learn a great deal about climate change since we are seeing less pollution from people staying inside?
Dora Mills is absolutely correct. You know, when you look at if you look at the city of New York, you don't have this in Portland, but we have some pollution. Or you look at Los Angeles, the skies are clear. When I was in Beijing and Guangzhou in January, the skies were blue. I've been in Beijing when I can't see the sun at all for 3 days. So it has had an impact. There's been a reduction in consumption of oil. So yes, there is a silver lining, and we are learning a lot about the fragility of our system. And I'm hopeful that this will lead to more support and more interest and investment in people in the healthcare professions, because over the past few years, there's been a dramatic reduction in support for public health. The other thing we've learned that's extremely important is that there are populations that are invisible to most people that are really impacted heavily by this. People of color, immigrants, people who work in factories and such, who don't necessarily have the wherewithal to shelter in a house. They're sharing a small space, and these people are disproportionately impacted by COVID. So this may also lead to some sort of push for economic redistribution. I don't know how you feel about that in your audience, but I think that we've gotten completely out of whack.
Yes. Yes.
Of course. One of the questions I have for you is, you talked about double-blind studies and control groups that's the only path to make sure we get the right medication and the right cure, the right vaccine. I've been following the case of I'm assuming one of your colleagues, Dr. Didier Raoult in Marseille. He's a very colorful figure, controversial, polemical, and all of that. But he's also very interesting. At one point, when he was being sort of pressured and being quizzed about the lack of doing these scientific protocols to make sure that his treatment is working, he said, "I am a physician. I'm not, in this case, I'm trying to treat a patient who is sick. I cannot wait for 6 or 8 months or 12 months or 18 months to do something about the patient in front of me. So is there a sort of a tension between a physician trying to treat a sick patient and also the emphasis on the proper protocols of doing scientific research?
So one of the first things you learn in medical school is the term primum non nocere. First, do no harm.
Mm-hmm.
And I think that people who do some kinds of experiments with humans without a data safety monitoring board, without rigorously testing their hypothesis, those kinds of things, are actually operating in a blind way. That's not what I mean by appropriate double-blinded study, where neither the physician nor the patient knows what he or she is receiving. When you go to see a physician, you put your faith in him or her, that they're going to do what's right. But if that individual doesn't really know, then to pretend that they have a crystal ball is disingenuous. And as I've shown you with the slide where I was talking about the data that came out of Brazil, there are people who are getting arrhythmias and dying,
Mm-hmm.
receiving chloroquine. Now, I would suggest that if the treatment is a success, but the patient dies, that's not a very satisfactory outcome. And I think that unless we know what we're doing, we should admit this. Now, I will tell you that I have friends who come to me and say to me, we believe we have to have compassionate use of this or that. And I understand that motivation. And if I truly knew, I would agree. But I'm not sure that compassionate use extends to, irrational use. We don't know that plasma trial, there's one plasma trial that I am aware of. I know the person who did it, and I think he did, the best he could and so on, but he didn't have a control group.
Mm-hmm.
He had a historical control group. He knew that people who don't receive plasma have a certain kind of an outcome, but he didn't use plasma from individuals who had not been exposed to COVID. So how do you know that it's the COVID antibodies or antibodies themselves? Because people get this drug called IVIG all the time, right? For a variety of conditions associated with autoimmunity or for treatment of or prevention of certain types of hepatitis and other disorders for which we at one point didn't have vaccines. I believe in medical science doing things as expeditiously as you can, as cleanly as you can, and tracking the results so that the moment you know something, you give the benefit of what you've learned to whoever has not gotten the arm that they might have received. But until you truly know what you're doing, I don't think it's a good idea. Even if this guy looks, I understand his viewpoint, but it's not rational.
I don't know whether you're aware, President Macron of France addressed the French people about extended their confinement till May 11th. And he said after which he will open up progressively, allowing progressively, daycare centers, schools, and come September, the university will be back in session. How do you feel about that?
I think we have to feel our way.
Okay.
So I'm writing an editorial right now in which I'm exploring the various things that could happen, that could be done, the drugs, social distancing, vaccines, talking about ways in which we could streamline and reduce the time required to get to a vaccine to perhaps a year instead of 18 months which would be a dramatic difference, actually, if you think about it. I don't think that this country is going to have the appetite to continue with isolation in place much longer. So the question is, how do we mitigate risk? We can invest in people who track the appearance of clusters of illness. We can ensure that we have testing widely available so that every time there's a cluster, we can say, as I talked with you about ring vaccination, who is it that this person, came into contact with, who we might test more than once to see whether or not they become infected. And then we have to get into the issue of how do we tell people who are infected and asymptomatic that despite the fact that they feel good, they have to go into isolation. And we're going to get into issues here of civil liberties and ethics that are going to be way above my pay grade. So that's for governments and ethicists to debate. But we are going to have to find a way to test and isolate so that we preserve, we are bringing that curve down. It is flattening. But it's not like what might have happened early on, where there were just a few cases and you could have sealed them off and protected the larger herd. We just don't have that now.
This is a humanities center, so excuse we're not experts in medicine. We are interested in you're interested in filmmaking and the liberal arts and anthropology. I wonder whether that gave you a different perspective on the practice of medicine in your career.
Very much so. And it allowed me to do work internationally that I could not have done. So I would tell anybody who's doing liberal arts, who has an interest in medicine, particularly geographic medicine or public health, the best preparation for that is, in fact, a liberal arts education. I'm a strong proponent of a liberal arts education. It teaches you how to think, how to write, how to present, how to interact. And these are things that you need to learn when your brain is still plastic.
Oh, that's very comforting to hear. We don't have a lot of other questions. I don't have a lot of other questions, but many of the questions I got revolve around these issues that we already discussed. By the way, I'm taking this opportunity to say hi to Tom and Mary Patterson, who are watching us live, and Tom's father, who's 96 years old. So hi, everybody. We have an audience now that's scattered around the city, the world, and the state of Maine. And the one thing, I don't like the notion of social distancing. It's something about it that sounds Orwellian or, dehumanizing.
Why do we call it physical distancing?
Okay, not better. That's better.
We gotta, the fact of the matter is we gotta have 2 meters.
Yes.
You know what a meter is. Most people in this country don't have a clue. Isn't it amazing that we don't have the metric system in this country? Whatever, anyhow.
So, but it's a very interesting, the concept of now, I was writing something for myself recently. Before this crisis, everybody was talking about the loneliness of people and how the human touch has become a luxury, for a lot of people. People, especially in highly industrialized societies, live very isolated lives and are socially alienated. And now all of a sudden we have this virus that even encourages that kind of confirms this, so encourages this kind of practice or this situation. And there's something very, that makes me uncomfortable a little bit. I don't know how to explain it, but it's a very interesting situation, you know.
It'll be interesting to see in the aftermath, you know, what the consequences are. Psychosocial, psychiatric, political. You know, when things like this happen, we have, you know, an increase in suicides, as you say, because people are isolated.
I have a question here from James, who now texted a question. Setting aside issues of ethics and civil liberties when considering ongoing social distancing, it appears that many epidemiologists focus only on the risk of infectious disease without considering the morbidity and mortality associated with economic collapse. We know that economic factors contribute to disease as well.
So, James, I agree with you. And this is one of the reasons why there's a big push to reopen the country. And we have enormous problems right now with unemployment. And we've invested trillions of dollars now in trying to bring everybody back from the brink economically. Also, another huge problem, malnutrition, children not being educated. All of this is true. If we could get the government, and maybe Susan Collins is listening, I hope she is, that we can train people who can ensure that we can safely go back to life as, it's never going to be quite as usual, but to life as it once was, that would be an extraordinary benefit. I think we are going to have to make hard choices as a culture.
Okay, yeah. And so it's choosing between what and what.
Well, there's some things that we don't need to do.
Yes.
In Eastern cultures, we don't have to shake hands. And certainly kissing on either cheek, that's a problem. I don't know that we're going to go back to that again. And I think masks, which in fact, for many years, when I travel in Asia, particularly Japan or Singapore, people wear masks even when there isn't a big outbreak because they try to protect one another.
Mm-hmm.
We could use a little more of that. People taking care of one another and caring about others and minimizing their risk. And I should say something about masks briefly. N95 masks, which are in such short supply that everybody wants, are not essential. Studies done during SARS found that whether you wore a simple mask called a surgical mask, which is not really sealed, or an N95 mask, which most people know how to wear properly anyway, was associated with a 60% risk of infection if you wore it intermittently, and a 70% reduction in risk if you wore it rigorously and continuously. So whatever you want to put over your mouth and your nose when you're out in public, go for it.
Yes. So in the end, so we're going to spend the rest of our lives, it looks like, trying to protect ourselves from this wave of viral threats that are coming, they're surely coming our way.
So I think we're going to have a vaccine in a year for this one. Then what we need to focus on is not so much this, we can move back toward normal. The issue that's going to come up will be, how can we identify these things while they're still someplace else? Develop the diagnostics, develop therapeutics, have platforms for vaccines, for example, where we can literally just plug in a cassette, for those of you who remember cassettes.
Yes.
That will do whatever it is we need it to do. That will make the protein, that will immunize people. We will have the ability to what we call repurpose drugs, We will have robots that will allow us to help take care of people remotely. We will learn from this experience and we will be better prepared. And I don't think we have to lose our humanity.
We have a question to you from Albuquerque, New Mexico, from a physician, Jeffrey Glassheim, a DO from a graduate of the University of New England, class of '84. And he says this: as an allergist immunologist on the front lines in 2009, 2010, as director at clinical immunology, including at the children's hospitals for H1N1 swine flu, and seeing how rapidly the vaccine was successfully produced due to homology with the similar viral agent of the 1970s, I am wondering why, since this novel virus has similarities, of course, to SARS-CoV-1 2003, why there is not more optimism about a vaccine in advance of the possible subsequent waves come autumn, winter 2020-21?
That is an excellent question.
Okay.
It's so excellent that I'm going to summarize it.
Okay.
The question is why, if we can come out with an influenza vaccine in several months, why we can't do the same with this. And the reason is that we have a whole pipeline for producing influenza virus vaccines where we can swap out components. We know a lot about how people respond to influenza vaccines, whereas this virus is new. And because it's new, we have to go through certain types of steps that we don't have to go through with influenza vaccines. That's a very good question. And it's something I'm going to add to my remarks in the future so that we cover it.
Oh, great to know. Well, I think that I've gone through all my questions. You've been very kind and very patient with me, and very.
My pleasure. It's my pleasure. And as soon as everything simmers down,
Yes.
we will break bread together.
Yes, absolutely.
Either in New York or in Portland.
Or Morocco here.
Morocco.
We are honored. We are beyond grateful. This is a huge thing for the university, for the Center for Global Humanities, for our audiences. I've never done anything like this before. We've never managed this kind.
So it's all uncharted territory, and it was a real pleasure. So I think what you guys are doing is terrific, and I encourage all of your students who might be anticipating or contemplating a career in science or medicine, go for it.
Thank you so much. Thank you. Thank you. Thank you.